check on learning. So you got a 22-year-old basketball player collapses during practice. So already, what are you thinking right there? I mean, you should already know, right? Should be leading to, yeah. Really the thing we talked about was hokum. All right, he regains consciousness after about 30 seconds. In the ED, he's asymptomatic, also had a stable on cardiac auscultation. You know, the harsh systolic ejection murmur at the left sternal border. That becomes significantly louder when the patient stands up from squatting. What is the most appropriate next step in management? Just send him home.
Yep.
I would think Charlie. Yeah, Charlie on this one. So we want to admit that patient. He's going to need to get an echocardiogram during this visit. Very high risk, especially with, you know, a syncopal episode. He's got, you know, increased risk of sudden cardiac death. Good, good. Let's see what else we got. 55-year-old female is brought to ED after a severe argument with her spouse. She complains of acute crushing chest pain. EKG shows 3 millimeter ST segment elevation in the anterior leads. She is taken emergently to the cath lab for suspected STEMI. Angiography reveals no evidence of obstructive coronary artery disease. Echo shows apical ballooning. What is the most likely diagnosis?
Takotsubo.
Yep. Takotsubo, broken heart syndrome. So like a stress-induced catecholamine release causes this condition. I always wonder if I've ever seen one, just because I send everybody to the cath lab and never, we're busy in the ER, so I never think twice after. I'm like, okay, well, they got their cath, hopefully they're fine. So I don't know how common it is, but we like to learn about it. So a 30-year-old male presents with sharp retrosternal chest pain that is worse when he lies down, relieved by sitting up and leaning forward, reports a recent viral illness, temp 100.8, auscultation, you got a scratchy sound, is heard at the left lower sternal border, EKG shows diffuse ST segment elevation, PR depression. What are we doing for treatment for this gentleman? Yeah, NSAIDs. NSAIDs. Is that what we're saying? Yeah. What about colchicine?
Yep.
Yeah, so that, and really it helps prevent recurrence, so colchicine is also an option in this patient as well, or Motrin and colchicine. Good. Let's do another one. 65-year-old female, history of metastatic lung cancer, presents to the ED with severe dyspnea. Blood pressure 85/60, heart rate 125, respiratory 28. Her neck veins are distended, heart sounds are muffled on auscultation. POCUS is performed, which shows a large pericardial effusion with diastolic collapse of the right vent. What is the most appropriate initial therapeutic step?
Bolus of saline. Fluids.
I hear bolus. Yes. So we want to obviously fluid resuscitate her. So get some fluids on board. Try to improve that cardiac output as much as we can. Good. And then, you know, this patient might require, you know, some sort of pressors eventually. Going to need some sort of drainage or pericardiocentesis. All right. 28-year-old IV drug user presents with fever, myalgia, chest pain. Trope is elevated. EKG shows sinus attack with non-specific ST wave changes. He has a new regurg murmur. Diagnosed with acute myocarditis, which the following findings would indicate poor prognosis and necessitate admission. And the troponin alone necessitates admission, that's for sure, but what else?
Probably C.
What do we think? I mean, you guys are probably like, I don't know who C is, so let's go with that. Yeah, he's got some fluid around the heart, right? So, he's got an effusion on there, so we're gonna, I mean, he's gonna be admitted just because it's myocarditis anyway, he's got elevated trope. But other criteria are gonna be your, some sort of effusion on there, especially one that's, you know, larger than 20 millimeters. All right, the systolic murmur associated with HOCM is known to change intensity with various bedside maneuvers. Which of the following will cause a murmur to decrease in intensity?
Right.
What do we think?
Alpha.
Will it decrease it? No. So anything that increases, you know, the size of the left vent is going to decrease it. So squatting from standing. So if there's, you know, standing and then they squat, you know, increasing it would be like the standing from squatting. Tricky way to ask it, huh? You're like, man, all the words we're looking for are all on there, and just about every one of those answers. Darn it.
All those look right.
Yeah. Yep. All right. There's Tinmally. And then today we'll talk about the usual stuff. We'll define it, we'll describe it, some pathophys, management, disposition. All right, here's our warm-up case, and this is really like one of the scary things just because the mortality rate's pretty high. But you got a 75-year-old, presents to the ED, he's got that sudden, severe, ripping chest pain with radiation to his upper back. Vital signs is, hypertensive, 197 over 99, heart rate 92, temp 98.6, and respiratory 24. So, you know, our safety net's going to be our first thing. So IVO2 monitors, ABCs. And then we got to decide what we're going to do for this patient, which is what we're going to talk about in this lecture today. This is a scary diagnosis, so we manage it a little bit more aggressively than other conditions just because the mortality rate's pretty significant. But we'll get into what we're doing here and the 2 drugs we like to use for this and why. And all of these patients, if they're diagnosed, we need a surge every consult. None of these patients are going home. All right, so there's a few different emergencies we're going to talk about today regarding the aorta. You know, the one we discuss the most is usually aortic dissection. There are other ones, like you can have some sort of ulcer that affects the aorta. You know, you can have a hematoma that develops as well. You can have an aneurysm or ruptured aneurysm. So those are all kind of lumped under these categories. And the one we'll focus on mostly is the aortic dissection. And all these other ones are something to consider, but are less common. And, you know, these are uncommon anyway, but it's something we always think about, you know, in the emergency department just because the fatality rate is very high. I think it's still pretty high even if we do manage it the best way we can. But, so normally you have some sort of underlying pathophysiology, like they have hypertension, like chronic hypertension, and they have some sort of insult or degeneration of the intimal layer of the aorta, and then it causes like a false kind of lumen in there, and you get blood that dissects. Other things, you know, that can are associated with it, like a bicuspid aortic valve, all those connective tissue disorders like Ehlers, Danlos, and Marfan syndrome. And then familial history is also one we consider for these. So if they have any family history of prior, like AAA dissections, that increases their risk. And then, you know, I feel like a lot of things like cocaine, amphetamine really does a number on the heart and vasculature, so that's something we always want to consider. I feel like people just don't do cocaine like they used to, though. Kind of disappointing, man. Like, I bet the 80s were great, you know? Everybody doing it. Other risk factors like cardiac surgery, so that, I mean, that hopefully makes sense. Any sort of surgery kind of affects whatever that structure is they were operating on. And then pregnancy can increase the risk as well. All right, so we're, mainly focusing on dissection, but aneurysm, is a different pathology, but it can also occur in the same location. For this lecture, we're going to talk about thoracic dissection mainly, but an abdominal dissection is also something to consider, but less frequent. We see more aneurysms there. And then we have most of the dissections we like to classify with, there's different criteria like our Stanford criteria, DeBakey criteria. The way I like looking at medicine, why would we use one, system when we can use like 5? That's how medicine works, right?
Absolutely.
But yeah, more common ones are going to be your type A. But here's the pathophysiology. So you got that intimal layer, the inner layer of that vessel, some sort of dilation, and then you get blood that creates like a false lumen or enters the intimal and your adventitious layer, and then you get a dissecting column creating that false lumen, and it's no bueno. So, men more common than women, and then normally at the ascending aorta, which is why that Stanford A is going to be our more common one. It affects blacks, greater and whites, followed by Asians. Really, we consider it in anybody that presents with the right symptoms. We see different pathology associated with it. So depending on if it's at the ascending aorta or if it's beyond those subclavian veins, we can also see stroke type symptoms with it. Then we got a bimodal distribution. So the very young in like connective tissue disorders, and then the really old with all of their comorbidities and heart disease, or there's the bimodal distribution for this. And then really you can see it anywhere. Like I had somebody in my unit with one. He had like chest pain. He was only like 36. He ended up having Marfans, and he didn't look Marfanoid, which is very sad, because that's what we learned. They all got that those Marfanoid features, but he was like in his 30s and got it. So something we always want to consider. Luckily, he survived. And then here's our different classifications, and really all of them kind of focus on the location. So is it more proximal on the aorta? So is it the ascending aorta versus the descending aorta? And then you have your DeBakey classification, which it just looks at the different portions of the aorta or the anatomical age. So is it ascending, doesn't involve the arch, descending aorta? We like to make it more complicated if we can. That's our goal for all of our criteria, scoring criteria and things like that, classifications. Either way, doesn't matter which one it is in the ER, this is concerning and we need to call the surgeon for these. But we'll talk about the steps we do before we're calling the surgeon or while we're simultaneously doing it. But here's representation, like a graphic representation of the different types that you see on there. So you can see the Stanford's a little less complicated, and it's just anything involving the proximal aorta or the ascending. That's what they're going to consider type A versus type B. Anything involving the descending aorta. And then, so depending on the site is going to kind of their history or what the patient's complained of, the subject complaint. So, more proximal, they may complain of like that abrupt, severe, sudden onset pain. It may be a little different depending on location. So the descending, they may not have the same complaints or it might not be as severe. And, a lot of times the patients we're working up for this or we're concerned, I think very rarely do I have them say, like, I got this ripping, tearing chest pain that radiates to my back. I hear it all the time, just not in patients I think have an aortic dissection. But your classic patient, especially for like board questions, tearing, severe chest pain radiating to the scapula. I'm trying to think of the last one I had. I feel like the impending doom thing, probably correct. Like any patient that like is in significant extremis have this look to them. I don't know what they're feeling, but their look makes me think like they know that there's some impending doom here. They do not look good. That's something we always want to, that's when your gestalt comes in. You're like, oh crap, I got to do something right now. But like what, 2/3 have that sharp pain, and then, less than 50% or so have that tearing or ripping associated with it. It is uncommon, so, the studies aren't, the best on these, so these percentages can be taken with a grain of salt. But, most of them will have some sort of anterior chest pain. If it's the descending, it makes sense because it could be lower, that they might have some sort of abdominal pain with it. And then one of the other concerns is not just the chest pain, so if it's anywhere near the carotid artery, they can start to have stroke type symptoms, so we want to do a neuro exam on these patients. And this one, like it says, if they have that chest pain and then there's like a neurologic deficit as well, we need to consider this in our differential diagnosis and make sure we rule it out. And then, further down you go, you might have an abdominal pain. One of the things we worry about is that like a tamponade, especially as it's closer to the heart or the proximal aorta. And then we want to know like any sort of history, so cocaine use, which I don't think, I just feel like I don't see a lot of patients on cocaine anymore. Pregnancy, any recent procedures, like if they have a history of bicuspid aortic valve, any sort of trauma, we're definitely going to be concerned with this. And then we'll talk about during the trauma lectures, the traumatic aortic dissection or ruptures, usually not compatible with life, but if they make it to the ER, then we're going to, make sure we're evaluating them. And then once again, family history. So AAA does have an association or a familial association. So if they have a family member, that can increase our suspicion a little bit more. I don't know, I think I've had one patient that once told me they had a bicuspid aortic valve, but something to consider. Like most people don't know they have a bicuspid aortic valve. So this person obviously had cardiac pathology and had been treated and seen for many different cardiac things and all about the cardiologists. But something to consider if they have bicuspid aortic valve. And then here's our differential. Really, our differential is the same for all our chest pain patients. So is it acute coronary syndrome? Is it a PE? Do I think it's even pneumonia, pneumothorax? Especially when they have these severe sudden onset ones, we want to think of more emergent things like pneumothorax, pulmonary embolism, stuff like that. Then we also have MSK, pericarditis, other causes are in our differential diagnosis. And then we talk about all these bad signs and symptoms, but most of the patients that present with it, we have, we find everything, physical exam is relatively normal. One of the differentiators could be like some sort of pulse discrepancy, depending on where the location of that dissection is. So you may have a pulse discrepancy or pulse deficit and, radial pulses, so one arm versus the other, or you might have, upper versus lower. We want to make sure we're doing a neuro exam, especially if this isn't our differential diagnosis. You can have that aortic insufficiency murmur with it. I like how it's a check for paraplegia or quadriplegia. I would hope the patient is paralyzed and they can't move their arms or legs. They're telling me that, or I'm noticing it on exam, but I need to check for that if I haven't noticed already. All right, so how do we diagnose this? This is, CT angiogram is going to be our, the way we're diagnosing it. Now the question is, when do we suspect this? And that's going to be our physical, our history. Really, a lot of it's going to be history related. We see then a pulse deficit. They have some sort of risk factors that we would suspect this in, like uncontrolled hypertension. They just do a lot of cocaine, things like that. We need to consider it, and that increase our suspicion, our differential, because most of the patients are all going to present the same. And that's what is interesting from what we teach, because everything's like differentiated, but really it's like chest pain. They might even say they have a cough, who knows, but this always needs to be in the back of our differential when we're looking for it or when we're evaluating a chest pain patient. And then once again, we can misdiagnose this, so if a patient's walking in, they have stable vital signs of something that can be missed. Also, if we're only relying on a chest x-ray, that's not going to be appropriate. Now, we will see certain things on chest x-ray that we'll talk about. Sometimes the pulse deficit is noticeable. I've never caught one on exam, but these are also very rare, so I haven't seen a ton of them, and I don't think anybody does. But once I had a medical student working with me, and they were like, "There's a pulse deficit," and he had crazy high blood pressure and like a really severe chest pain. I was like, "Oh man, this is gonna go bad." I couldn't tell there was a pulse difference, but maybe his fingers worked better than mine. He ended up not having it, so I think I was right, but whatever. Still, we were concerned. And then if they, they may present with syncope, which is usually a poor sign. All right, so is our EKG gonna diagnose this? No, but they do have chest pain, so we wanna get that immediate EKG, especially at triage. There can be, associated changes which are very non-specific. Really, like almost everything we see in chest pain is like non-specific ST&T wave changes. That's what we see probably most commonly on all our EKGs. Nothing else really jumps out, like, yeah, okay, new Q wave and very small percentage or ST elevation. And then EKG is normal in like a third of the patients, so. 20% don't present with pain. I'm wondering how we diagnosed them with it. What did they present with? All right, so there's no real biomarkers. D-dimer is not super, not reliable at all for this. Very low specificity. Troponin isn't helpful, but we're going to get our normal chest pain workup, so we'll get cardiac biomarkers. We'll get CBC, BNP, coags, all of that. If this is something we're concerned for, just because it involves aorta and large surgery, we want to get a Titan screen or a Titan cross match with these patients because we know they're likely going to need blood. And then a chest x-ray. So chest x-ray can't rule it out, but there's definitely findings on there that can help us, that can increase our suspicion for this. So wide mediastinum is going to be the biggest one, and then that abnormal like aortic contour, which both are kind of similar to a wide mediastinum. So anything abnormal in that like aortic area, that's when we're going to be concerned that this is going, that this may be a dissection. And then, other things, yeah, deviation of the trachea, that's not good if we say that. All right, and what do we see on here? Lots of positive arrows on there. So yeah, it's a normal chest x-ray, right? But that's what it should look like. You have your ascending aorta, your descending aorta, you have your aortic knob there, or the arch, and that's what we're evaluating. We're looking for any sort of abnormalities there. And then here's what a wide mediastinum looks like. So this one's grossly abnormal. You see that, widening where the arch is, it's extremely large. I mean, you see it enlarged on the right and left side on this x-ray, but really anything like they say over 8 centimeters at T4, it's gonna be a wide mediastinum. I don't think you need to measure this, you just look and you're like, oh, not good. Here's another one. This is the calcium sign. So you got like a calcified outline of the aorta, and then soft tissue kind of projecting beyond it. And then how do we diagnose this? So this is going to be what we use to diagnose this. It's going to be CT angiogram. So what does that mean? It's a CT scan with contrast, and that contrast is timed in the aorta, so we can evaluate that most appropriately, or during that phase of the CT scan. It might have been called, some people call it aortogram. Really, CT angiogram of the aorta is what we're getting on these. And it's looking for a false lumen dissection. There can be flaps. We'll have some images on here that'll hopefully give you an idea how it's going to look. So what do we see on here? Positive arrows, yes. Like, does everybody understand that, what we're looking at? We have the aorta there. And then this is, the ascending, and then we have a false lumen, and then we have our true lumen. So it's a little bit brighter on there, so the contrast is flowing appropriately when it's going through the aorta where it's timed. Then we have our descending lumen as well, or the aorta, and then you have that like little dissection there on the outside as it's descending down. Here's another one. So got another positive arrow sign on there, but you can, see that dissection there. It looks a little bit more prominent how far it's going on this image. You guys good with reading CTs?
Experts.
I'll say if any of you say yes, then I'm going to start worrying. So, my advice, especially in phase 2, when you're, in your rotations, look at in real life, you should look at every image you order, not just the results, which sounds crazy. Like, why wouldn't I do that? Well, it's because it's like getting access to the PACS machine. Even as a brigade PA, I deployed, came back, and then I couldn't get access to the PACS machine for like 6 months. And I'm like, this is like not great for practice. So, look at all your images. But when you're in phase 2, like especially in the ER, we have a viewer that everybody can look at. It's a big screen. Every ER usually has them. And so just pull up the images on there, or when whoever you're working with, make sure you're shadowing them and you're like, what are you looking at on that CT scan? And then pull them up, look at them all. And that's the only way to get better at looking at them, is looking at lots of CT scans, lots of normals. It takes a long time, but hopefully it will eventually make sense and something jumps out. Just like when you're doing physical exams, all you guys know are normal right now. And so when you see, when something's abnormal, hopefully you catch it and you're like, okay, that wasn't normal. That wasn't what I was used to seeing. Other ways we can diagnose it, so echocardiograms or transesophageal echo, so we stick an ultrasound probe down their throat or in their esophagus, and then we can also diagnose it this way. This is not something we do initially in the ED. They'll have to have some sort of sedation for this, so this is not something we're going to utilize. It's something on the inpatient side they may use to evaluate it. And then MR angiogram is, a great test as well. It's just not something we're able to do in the ER, unfortunately. Here's what it looks like on the ultrasound. So you have your true lumen, your false lumen, you have that intimal flap on there. And then we can put color or Doppler onto our images and evaluate whether there's flow in which direction the flow is going, so whether it's going towards or away from the probe. And you guys will learn that in block 5 when we're scanning. Hopefully we don't find any aortic dissections. And then here's another image, so you have, your intimal flap in there. This doesn't have any color flow on it. All right, so what do we do when we treat these? So one of the issues is going to be, their heart rate and their blood pressure in these patients. So these are one of the few patients we want to drop their blood pressure immediately. But the first thing we want to do is control the rate. So we want to control the shear stress onto that vessel so we don't have any further dissection. So we want to give them some sort of medication for that, which is going to be our beta blockers, our best medication for it. And we like to use Esmolol for this because it's short-acting, fast onset, and we can turn it on and off quickly if we need to. So this is like a rapid infusion we're going to give of Esmolol. And then we want to manage their blood pressure after that. And sometimes that's usually going to take another medication, so a vasodilator on top of it. But for all these patients, we want their blood pressure less than 120. And then we can add like our nitroprusside on top of it or a vasodilator after we've given that antihypertensive, or after we've given that rate control medication, which is the beta blocker. So prior to any sort of vasodilation, control the rate first, and then we need to vasodilate them with nitroprusside. So beta blockers first line, what we're going to use. Now some patients can't tolerate beta blockers, so we can look at our calcium channel blockers are something we commonly use to control the rate. especially like our diltiazem is a very common one. So if they have an allergy contraindication to beta blockers, we can give something like diltiazem or one of our non-dihydropyridine calcium channel blockers. You can use nicardipine, which is a dihydro calcium channel blocker. It is not as effective, but it has been used with success to replace the nitroprusside. Then we can also use nitroglycerin, which is another great one. Labetalol theoretically can control the rate and the hypertension. So we can consider labetalol as well. It usually doesn't control the blood pressure as well as our vasodilators. So, you know, depending on your facility, that might be something they use, but we don't commonly give labetalol for it. Then, like I said, if a beta blocker contraindicated or allergy, we want to use our diltiazem. It's going to be our go-to after that. And then what do we do for them definitively? They need to get it repaired. So we got to call the surgeon. And this is normally like cardiothoracic surgeon. It's going to be the most common person we call. Depending on your facility, maybe vascular covers it. Everywhere I've been at, cardiothoracic surgeons who are contacting. And it doesn't matter where the location is for us. That's more like surgical planning. So they may manage some of the descending ones without immediate or emergent surgery. But we're still treating the ER emergently, so we're calling them. They can do endovascular repairs. Normally it's like open heart, but they may medically manage it for any of the descending ones. And that's probably because these patients are going to have significant comorbidities associated with the elderly. They're not great surgical patients, so they have a pretty high chance of mortality. Even going for like a standard operation, an outpatient, one-day operation, they already have increased risk, so this makes it even worse. And then they can use some stenting. There's like endovascular repair. Some of them aren't as effective as others, but that's going to be up to the surgeon. I don't really deal with that. But the goal is they can use some sort of stent and then stabilize that lumen so we don't have any more blood dissecting down it. So all these patients, we're calling the surgeon, and then they'll decide whether they're going emergently to surgery or whether they're going to admit them to the ICU for monitoring first. They're going to need, careful monitoring. Since we're controlling their blood pressure and their heart rate, they're likely going to end up, in the ICU if they don't immediately go to surgery, just because it requires like continuous IV medications. For the ulcers or hematomas, like I said, it's unclear clinical course, so that's going to be consult a surgeon, and they're going to decide what the management is from there. Some of the ones with, a lot of times will have other underlying risk factors. I want to say the ulcers are like associated with other types of surgeries that they've had in the past, so they get a little bit more complicated, but all of them are going to be managed inpatient by the cardiovascular surgeon. So they have an increased risk in pregnancy, so it is something we want to consider. It is rare, but usually in the later trimesters or postpartum is when we see it. So it does have, fourfold increase. So we need to think about it in pregnant patients that present with chest pain, especially like sudden severe onset. And then obviously if they have Marfan syndrome, that's something, we increase our spidey senses a little bit more that this could be a dissection. And then if we're, if this is something we diagnose in pregnancy, we need to have obstetrics on board, especially if they haven't delivered yet, because it might be something that has to happen simultaneously. And then what kills them? So cardiac tamponade, certainly one of the complications we worry about that can affect these patients or increase their mortality. They can then have aortic insufficiency, so that valve gets unseated, and then they leads cardiogenic shock. It can have aortic free rupture, and then always at risk for like end organ ischemia if they're not perfusing all of the organs because of that dissection. They're not getting enough blood to that area. And let's talk about hypertensive emergency and urgency. So these are fun ones in the emergency department, very common complaint. I think I have one on Sunday right when I was about to leave. The guy had like and you guys consider like high blood pressure 140 over 88 or something. But we routinely see significantly elevated blood. I think this guy's was like 200 over 125 or something when he came in. So we'll talk about what we do for the management for these. All right. So we have hypertensive emergency and urgency, although they said urgency isn't a thing anymore, but it still is, so I don't know what that means. But really we classified as hypertensive emergency. They had severely elevated blood pressure with some sort of end organ damage. So when we think about where that elevated blood pressure can affect, we want to think anywhere in the brain. So do they have any sort of headache, stroke type symptoms, papilledema, and then we want to look at obviously the heart. So they have a chest pain. Are they having any problems with breathing, their lungs? It can also affect, kidneys. So that's what we're really evaluating these patients, any end organ damage. So patient comes with, the blood pressure that's elevated. There's no agreed upon number on there. It can present, most people say over 180. Some say over 200 is what we consider severe blood pressure elevation. And you guys will see once you get phase 2 that, especially in the ER, patients in pain. Like I'm surprised when somebody has like a 118 over 76 blood pressure. I'm like, man, that's great blood pressure. Because normally everybody's at least in the 140s, in my opinion. But one of the issues we have with this is what do we do for all these patients? So especially with the new watches that are out there, all the machines people have at home, we see this a lot. And so the question is, what do we work all these patients up? So what's important to remember on these, we need to do a good history and physical exam. And based on that physical exam, so are they symptomatic is the first thing we need to think about. Because asymptomatic hypertension in the emergency department, even if it's elevated in hypertensive urgency, we're still not going to do anything or a full complete workup for them if they don't have any symptoms. So if we can get them good follow-up, we don't do anything for them. Now, if they're symptomatic, they have a headache, they have vision changes, they have chest pain, shortness of breath, then we're gonna get EKG, we're gonna get our labs, so troponin, cardiac biomarkers. We wanna look for any like end organ damage, so kidney dysfunction, so we'll get our BMP. We'll look at a UA and we'll get a chest x-ray on these patients. If they're having a headache, we'll get a CT scan. But since, a lot of patients present with this, it's not a standard we're gonna be doing everybody. So if they're symptomatic, that's when we're gonna walk down this route of ordering all these tests. If they're asymptomatic, then we just need to do a thorough physical exam. We need to evaluate for any papilledema, like the guy that I saw on Sunday, the freaking ophthalmoscope. Every time I tried to look on the left side, the light would go out, and so it took me like 5 minutes. I'm sitting in front of him, I was like, don't worry, we're gonna get this eventually. And I'm like yanking the cord, turning. So check for papilledema in these patients. That was the moral of that story. Do a good neuro exam on these patients, and then decide whether you need to do the workup or not. So symptomatic, we're gonna do the workup. Asymptomatic, we're not. And our goal is to figure out any end organ dysfunction in these patients. If they don't have any, then we're likely not going to do much for them because we don't want to acutely lower their blood pressure. If you think about it, the patient's probably been living with that blood pressure for, God knows how long, probably months, years. So when we start acutely lowering things, we run the risk of like perfusing, we lose perfusion of the brain, their body becomes adjusted to that. And then we can then cause stroke type symptoms just from lowering it. So it's not something we do acutely in the emergency department unless we have end organ dysfunction. If we do have to lower it, then it's just small increments. So like 20-30% is what we're gonna lower it. Now, if we suspect they have other conditions like dissections, things like that, then we may manage it more aggressively and lower it a lot faster than we would prefer, that the body prefers. If it's ACS, Or pulmonary edema, we can use like our vasodilators, nitroglycerin dissection, like we said, esmolol. And then other ones like nicardipine is a good one if we don't suspect any of those other diagnoses or pathology in these patients. But there's lots of different options. Labetalol is probably a very common one you're going to see for acutely lowering hypertensive emergencies in the emergency department. So, hypertensive emergency, they have signs of end organ dysfunction. Urgency is when they have that same elevated blood pressure, but we don't have any evidence of end organ dysfunction. These ones we don't want to acutely lower or do anything for the blood pressure. Now, that's what all the papers and studies say, but it is, sometimes we will prescribe them something to go home with if they're not on medications anymore. It's important to, get a good history. If they ran out of their blood pressure medication, we likely are going to refill that for them. Or we can consider doing a take-home medication. And if we've done a complete workup on them, that's something we might do, especially if it's like over 200, we may consider that. But if they have good follow-up, then hypertensive urgency will usually discharge them, follow up with your PCM because they need to manage them. We don't usually like to give a blood pressure medication and worry about tanking their blood pressure and sending them home. All right, so there's our check on learning. 40-year-old male, he had a past history of a bicuspid aortic valve, presents with sudden onset severe tearing chest pain right in the back. He's got a pulse deficit. So what are we doing for the workup for this patient? Yeah, IVO2 monitor, good. Yep. So initially, if we suspect this right now, before we get the CT angiogram, because it takes time, our immediate treatment is going to be our safety net, IVO2 monitor, fluids if needed. Then we're going to patient has these symptoms consistent with it, so we'll start lowering that blood pressure right now because the CT takes a little bit of time to get the angiogram. So we'll start lowering, we'll control the rate, then we'll lower the blood pressure while we're getting him to the CT scanner. But CT angiogram is going to be our diagnostic test of choice. What do we see on chest X-rays? What might we see? Wide mediastinum, good. And then what do we do for treatment for this?
Esmolol.
Yeah. Well, yep, esmolol, nitroprusside. What's definitive treatment, or what are we doing? Who are we calling? Cardiothoracic surgeon, good. And our disposition, they're all getting admitted. All right, what questions you guys have? Does that all make sense?
Absolutely.
Yeah. All right. Well, let's take a break. Be back at 9.
Yeah, no, I was about to tell you. Not sorry, not sorry. Yeah, I'm not surprised, dude. He's still in the movie. I'm so mad. I just got this. Of you and him. I'm not even stressed. I don't even feel the pressure. What you got? Yeah, he's close to developing this. My ex-wife. My ex-wife's close on the second chance. How long did we go on?
Sometimes it's like right away.
For all the civilian connections, right after Kyle. Well, don't you think Vegas, go the other way? Tell that they go or I can take this like shortcut.
Great property. Oh, yes.
That was opposite. Jam took it. They straight right
It's like a small type of thing, so I think it's there.
She did too. She that's why she did. That's all.
What is the major
She was a good stretch. You know what? It's oversimplified.
The only thing you lose is
The bank balance is coming in, right? Whenever I put on my check.
tell my wife when I get that extra money, they're gonna work it back.
Have the what's it called? It's a laundry shroom.
How big?
It's in a laundry shroom. You can just take
I threw the kitchen sink out.
start throwing like 20% into his face.
What else are you going?
So for us, I switched over because I contribute like so it's actually really 17%. 17% of my So if I don't have anything, if I don't have anything, if I put 0% into my safety, it will take 1% and put it automatically. If I put 5%, it will match up to the 5%. So that's the good is, so if I contribute 5%, it's really not So, and right now the market's crazy. I just lost just from sitting in but I was up.
Where do you have them in?
Robinhood. I have them in Nvidia, Arrow, it's like Arrow Fire, whatever, it's the aerospace.
You don't do it in TSP?
I do 12%. I invest on the side.
Where do you do TSP?
What do I do? It's kind of split. I have like which I did LC for days when I first did it. Only like 20 people so 55, 65, all that. So that like right when that happened, I threw it in like 10%, like $5,000, and it's already gone up like because if you throw it in those, it's very conservative. But I started at like 3,000, not all the way up to like 11,000. So I did that, so I just kept it in there, and then I do like 30% into.
I right now is really good.
I is amazing. Right
S and C are coming back up, but I split up to 59.
Yeah, no way. I don't like that. That's my biggest fear of the whole process.
Look at it when it's 5 minutes. Because like, because if you go right now, like I watch it and I'll see, like I said today, I lost 2.
There's groups to follow that tell you how to play with them.
So I have did you see what instructions right? He's trying to build his portfolio, so I just give him 100. I need my ball after years, but you be able to go look and see if I can turn it into his profile picture. Maybe. And I'm like, just be stupid. So he'll like call me and like, switch over like, so my phone where I was like, this is what you're doing. Yeah. So you're watching 2 years. Maybe just completely didn't know. Just like really close, it's like you're in it. It's exactly.
Yeah, I follow this lady and she's
Yeah, they did. I didn't know. He was dead. Yeah. We thought we got called for it. Yeah, I just watched the dead dude, so I think I should do that. It was so weird. Just got done. Big Bang.
All right, let's keep this party going here. We're going to continue our cardiopulmonary pathology. We're going to move into heart failure. But before we do, let's do some check on learnings. All right, 62-year-old male with a history of chest pain with activity over the last 24 hours. Brought in by his wife, denies current chest pain while at the ED, but he noted pain return when he walked in from the parking lot. He's never had this type of pain before, but has a history of hypertension, diabetes, hyperlipidemia. There are no ST segment elevations on EKG. However, there are non-specific ST and T-wave changes. Initial and repeat troponins are not elevated. Chest X-ray without acute cardiopulmonary changes. Vital signs are stable, and his calculated heart score is 6. What is the correct disposition for this patient? What do we think? Yeah, C. So this patient, has a moderate heart score. So it's not somebody we want to send home. We want to put them on what we call, some places, usually military facilities, call it the heart pathway. So they get admitted for risk stratification. So this would be like an unstable angina. They would get admitted so that they could get a stress test and an echocardiogram. Good. All right. We got 65-year-old male presents to the ED, 1 day history of acute onset severe pleuritic chest pain with 4 episodes lasted 15 minutes each. Pain was worse when lying flat, relieved by leaning forward, denies fever, diaphoresis, denies any medical problems, not taking any meds, which is concerning. 65, no comorbidities, no medications. EKG shows diffuse ST segment elevations and PR depression. Fill the following items, which one meets criteria for the patient to be discharged and treated as an outpatient. Presumed viral pericarditis. D. Good. Let's try another one. 62-year-old male. See, I was changing it up. Not just 65-year-old. 62-year-old male, long history, uncontrolled hypertension is being managed for a confirmed Stanford type A dissection, blood pressure 210/120, heart rate 110, primary goal medical management, reduce aortic wall stress. Which of the following represents most appropriate pharmacological strategy? B. Yeah, B. Yep. We just talked about it. Esmolol, nitroprusside. Blood pressure is not normal or below 120. Good. Good, good. What else on here? What if you had a beta blocker allergy? What would we use? You could use a cardipine. Yeah, Dilt is probably our preferred one for rate control first. But yeah, nicardipine. You can use nicardipine. Yeah. They both, I mean, diltiazem is probably a little bit better. But it's all right. I wouldn't put them both on a test. At least I don't think they're both on it. Maybe they are. Might have to change. 75-year-old male presents with the sudden onset of severe ripping chest pain radiating to his upper back. Blood pressure 195/100. Chest x-rays obtained, which shows wide mediastinum displacement and mole calcification. More than 1 centimeter from the outer aortic border, which of the following is the most appropriate next diagnostic step? What do we think? Charlie, yeah, CT angiogram. Yep, we need to get it. Good. Oh, we got another one. 66-year-old male presents with acute severe chest pain. EKG is normal, initial troponin is negative, you have a high suspicion for an acute aortic syndrome, which is the following chest x-ray finding is the most common abnormality seen in aortic dissection. So it should be correct. D, wide mediastinum, good. All right. There's our references. And we're going to talk about heart failure, some of the pathophysiology, you know, what the presentation looks like, how we diagnose it, and then what our disposition is going to be for these patients. So it's a big, you know, it's a large topic, but in the ED, you know, there are certain, we kind of lump them into different categories, and we'll talk about those. But our warm-up case, you got a 53-year-old man, presents with shortness of breath and a headache, has a history of diabetes and hypertension, but hasn't taken his meds because he can't afford them. And this is a very common way heart failure presents, actually. They can't afford their medications and they present. So he's okay until 4 days ago when he developed mild exertional shortness of breath, dyspnea and exertion, which I think will be the same thing, right? Exertional shortness of breath and dyspnea and exertion. Okay, has worsened since then. He had 2 to 3 pillow orthopnea last night, developed a band-like headache this morning upon awakening. And then he is complaining of substernal chest pressure, unlike his previous angina, which started last night, 4 to 10, doesn't radiate. Nice nausea, blood pressure 200/125, heart rate 128, respiratory 34, temp 98.9, SpO2 90%. So, what's on our differential? Hopefully heart failure, because we're talking about it today. And then we'll talk about our treatment priorities. If I was teaching this another semester, I would delete these warm-up cases. That's just me. All right, and then here's going to be our approach, which we'll talk about today. And there's a couple different presentations or different ways we lump these into categories. So whether it's, you know, heart failure with hypertension, without hypertension, and then whether it's cardiogenic shock or whether it's like flash pulmonary edema, also called SCAPE. All right. So heart failure, you have, your heart can't meet the demands of the body is basically is the bottom line for it. So it's not meeting the circulatory demands. And then we kind of categorize it into what the disease process is, on whether we think it's like right heart failure, left heart failure, whether they have a preserved ejection fraction versus reduced. Most of these are going to be admitted to the hospital for these patients. Very few of them we're going to send home with some sort of heart failure exacerbation or decompensated heart failure. And it has a poor prognosis, so most of them are going to unfortunately not make it past 5 years, or about half won't make it to 5 years. It can be difficult to control these patients. And then here's our cardinal symptoms. So, that dyspnea on exertion or shortness of breath is usually going to be the common complaint they're going to present with. They'll have fluid retention. So you'll see that edema. They'll have fatigue. And then the difficult part is there's no, one specific diagnostic test to decide whether they have heart failure. And then it's, a clinical diagnosis can be precipitated by like anti-inflammatories, beta blocker use. And it depends on which type of heart failure they have, on what types of symptoms when they take those. But, one of the peptides that our body creates is that B-type natriuretic peptide. So this is something that we can measure when they have a heart failure exacerbation. But it can also be elevated in other conditions. So it's, you have to apply it to the right patient and the right sort of pathophysiology when they present. Lots of different ways to classify it. So we can look at acute versus chronic. We can look at what side of the heart, so right versus left, can present with different symptoms. And then is it systolic versus diastolic, how severe are their symptoms. We also have like our New York Heart Association functional classification. So whether they're asymptomatic versus, dyspnea, some sort of symptoms on exertion versus, mild, and then severe symptoms while doing nothing. But what we like to use is their ejection fraction. So this is the more common nomenclature we're going to describe these heart failure presentations with. We prefer it over congestive heart failure because they might not have signs of congestion or volume overload, which is why we like to utilize this terminology. However, we will have to have an ejection fraction or measurement on them, so they'll have to be diagnosed typically before we can describe these. But we like to categorize it like heart failure with reduced ejection fraction versus preserved. So we say half ref or half PEF, and that's a left vent ejection fraction of 40% or less is going to be reduced, and then 50% is going to be preserved ejection fraction. All right. So what do they present like? So it depends on, most of them are usually going to have some sort of chronic heart failure, but we have like an acute non-chronic presentation. Sometimes we'll call it, if they have like significant derangement of vitals, acute decompensated heart failure. But they'll usually present with some sort of gradual increase in their symptoms. So they normally notice over a couple of days they start to get worsening shortness of breath just walking up the stairs, and then it progresses to at rest. And then they'll typically present, if they know they have heart failure, like I said in the previous lecture, we want to know like their dry weight, and they'll usually say I've had like a 10-pound weight gain over the last couple days. And then they start to have the shortness of breath, and then signs of volume overload. So that's your typical presentation. We also want to consider other presentations. So somebody, likely isn't diagnosed yet, you can have high output heart failure. So from an anemia or thyrotoxicosis is something to consider. And then they can have like isolated right heart failure, which might not have the pulmonary congestion. They may just have JVD, lower extremity edema. So these are all kind of dependent on where the heart failure is in the patient. And like it says, history of heart failure is the most useful historical parameter. Yes, so history of heart failure. Other things to consider if it's their first episode of it, or if they aren't diagnosed yet and they present with it. If they have a history of hypertension, any other comorbidities like diabetes, any valvular diseases, elderly, males, obesity. I feel like a lot of the heart failure patients I treat have obesity, and maybe that's because their exercise tolerance isn't as great as it used to be, but I don't know if it's the chicken or the egg with these. And then most common symptoms are going to be that dyspnea on exertion when they present. So they'll have, going upstairs, walking from the car has been worsening. Then they might say it's worse at night when I'm laying down. I say I have to sit up, I have to sleep in a chair, and then might have orthopnea, edema. And then what do we see on our physical exam? So, we're gonna evaluate whether they have any sort of, cardiopulmonary or lung findings. We wanna look for like an S3 murmur on these patients or any other types of murmurs that we might hear that could be related to this. We wanna check whether they have any sort of like peripheral edema or signs of volume overload. Some of them may be tachycardic, tachypnic, depending on how far along they are, how long they've had the symptoms, or how significant the heart failure is. And then other things like, they might be cachexic, especially if they have significant other comorbidity associated with it. And then here's our, signs of kind of volume overload that we want to look for. So do they have any hepatomegaly, right upper quadrant tenderness, ascites? And then we check for that edema. That's what pitting edema looks like. You press your finger, it still leaves a dent in there. And we call that pitting edema, which we commonly see in these patients. And like I said before, we kind of judge it like 1+, 2+, 3+. Don't ask me what that exactly means. Like, I use it all the time, but I'm like, press my finger and I'm like, yeah, it looks about normal, like a 2+ in pitting edema. And then my finger stays there longer. I'm like, yeah, maybe 3+, maybe 4+. And then we kind of judge it how far it's going up. So is it to the ankles, is it to the calf, is it the knee, is it the entire lower extremities? And then what's anasarca? Yeah, it's like their general whole body looks edematous. So diagnosis checks, for these patients we do our, normal chest pain workup for these patients. So we want to get our chest x-ray, our EKG, our cardiac biomarkers, our CBC, CMP, BNP, and then we're going to evaluate from there. Chest x-ray, you might see that cardiomegaly or enlarged cardiac silhouette, and then you can see pulmonary edema on there, like the cephalization, the vessels. But some of them will have a normal chest x-ray on presentation. What do we see on this one? Yeah, we see pulmonary edema, right? It's not normal, that's for sure. So you have, you can just see all that fluid leakage there. So this, this is what we call like an alveolar edema. EKG, so this is to rule out other causes or precipitants. So are they having a STEMI right now? Are they having any ischemia or NSTEMI? We might see left ventricular hypertrophy, left atrial enlargement. A lot of it's going to be related to their comorbidities. And then we're looking for anything that acutely precipitated this episode. One of the great bedside tests we can use is our point-of-care ultrasound, so we can take a look at the lungs on patients. And there are some, findings that can be easily obtained at the bedside if our diagnosis is in question or we need to confirm anything. But we can see any pulmonary edema with the ultrasound. We can also look for a tamponade. We can get the left ventricular ejection fraction or a rough estimate of ejection fraction. And we can look at the volume status too. So there's a lot of different questions we can answer, but one of the things we'll talk about during our point-of-care ultrasound lectures is, and this should be with anything you're doing in medicine, any test you're ordering, like what is the question I'm asking? Like, why am I ordering this? So if we're just shotgun blasting orders, that's not appropriate. We have to have a certain question in mind, like what am I looking for? So for heart failure, like is there signs of any pulmonary congestion? Is there signs of volume overload? So we're looking at the collapsibility of the inferior vena cava, we're looking at ejection fraction in the heart or any tamponade. So those are kind of the questions we're asking and looking for. And then we need to perform our test to whether confirm or deny the pathology we're looking for. And that should be with anything, like, we don't just order a CBC because that's what we do, even though we sometimes do that, but that's not exactly appropriate. So if you're not trying to answer a certain question, we probably shouldn't order it. All right. So the first thing we're looking for is pulmonary congestion, which you guys remember from radiology, like B lines on a chest X-ray. It's like curly B lines or whatever they were called, which aren't super accurate, but something we're looking for. Or not super common on the chest X-ray, but something we're looking for. So we see the similar thing on our ultrasound. So we'll see B lines, and it almost looks like a flashlight or some sort of beam going down to the lung, and it'll hopefully make sense when we look at it here in a second. And if we have 3 or more of those B lines in one costal window, so in between one rib space, then it's going to be highly specific for some sort of pulmonary edema. So here's what our ultrasound looks like. So you see the R on there is rib shadow, so we're placing that ultrasound right over the, right in between the ribs, and so it has usually a large area that it can scan, so you'll get some of that rib shadowing in there. And what we're looking for is that, this has a positive arrow sign, but we're looking for that shining, like light beam coming down. So we call it ring down artifact from that pulmonary edema. And that's going to be like a positive find, especially if you have 3 or more in one rib space. And it makes sense when you have a video of it, which I think I have in the next slide. So if you guys see that ring down artifact, it looks like someone's kind of shining a flashlight in there. So if we see 3 of these per rib space, that's going to be a sign of pulmonary edema. Here's another one, so you see lots of that vertical artifact on there, those B lines, so that's going to be positive. And then one of the other things we look at is for signs of volume overload or congestion is going to be our inferior vena cava. So let me kind of shine it again, and or play it again, and we'll see. You can see the heart beating there, and then let me kind of laser. So this is your vena cava here, and what a normal vena cava should look like is that collapse you saw on there. So it collapses in, it presses on itself, and then if our size is over 2 centimeters or less than half collapses, then that could be a sign of volume overload. So let's see if we got a picture of that coming up. Yep. So if we look at this one, we don't see really any collapsibility of that, right? So that's a non-collapsible inferior vena cava, and that would be indicative of some sort of volume overload or elevated central venous pressure. So there's a collapse, there's one that collapses, that's the normal, that's what we hope to see. And then here's our normal ejection fraction. So like I said, we have that endpoint septal separation, so you see that valve kind of opening and hitting the interventricular septum there, and that's what we would consider a normal ejection fraction. It's just kind of a rough estimate, we're not measuring it, although some of the fancier new machines you can take a picture and then circle it. It's still kind of janky, but they have even newer AI ones that will calculate it all for you, because the machines you have to use, you'll notice when you start using them, you have to use the little trackpad and circle the area, and it's very difficult to get an accurate measurement. So the newer machines will have AI that calculates it, which is kind of cool. And then here's what an abnormal looks like. So you guys see how you're not getting a lot of septal separation or endpoint septal separation. So this would be decreased ejection fraction. We don't know how much, obviously, but it's a rough estimate because we're utilizing these at the bedside on these patients just to help us help our management acutely. So we don't really need an exact measurement. We just know, okay, that it looks like there's a reduced ejection fraction and consistent with heart failure. What labs are we getting on these patients? So we need to think about the other causes. So like we could have a high output heart failure. So we can get a CBC to look for any sort of anemia on there. If it's a thyrotoxicosis, we'll get a TSH if we're concerned for that. And then we want to look at a basic metabolic panel. So we're looking at electrolytes, we're looking at kidney function. We also want to look at liver enzymes because you can have that congestion of the liver. So that's something we're going to evaluate. The BNP can be helpful for heart failure, especially for like an exacerbation. And then we want to get cardiac biomarkers, UA, and then depending on how they present, we might get a VBG with this as well. So if they're hypoxic, hypnic, they're sick, we'll get a VBG. And then we always want to add mag and phos on there when we can. So the BNP is probably going to be one of the more helpful ones, especially if it's undifferentiated, we don't know what it is, so it might just be COPD versus heart failure, even though it could be elevated in COPD too, so it's not the definitive test. That's why we have to utilize our test in the right patient population to kind of differentiate it. But this can help us in the acute setting. And here's our different values, which you don't need to memorize the values, but there are different types. Most places are using like the Pro-BNP now, so I don't see a lot of facilities using the older one, but those are kind of the cutoff points we use for heart failure. It's likely versus unlikely. All right, so what are we going to do for these patients? So once again, our safety net, so if they're hypoxic, we're going to give them oxygen. For these heart failure patients, if we know that it's heart failure, BiPAP or high flow nasal cannula works really well in these patients. And then we're gonna, evaluate circulation, look at their blood pressure. Do we need to diurese them, or do they need pressure support? Are they hypotensive? But airway and breathing is going to be an extremely helpful portion we utilize. So we want to get like end-tidal CO2, our non-invasive ventilation, which would be like our BiPAP works really well on these patients. However, if we can't get a good seal on it, if they're altered in any way, or we're worried about aspiration, we may not want to use BiPAP. So we have other options like high flow nasal cannulas now that we can utilize as well. And there's like our high flow, so you're getting a lot more oxygen. Normally nasal cannula, I think, caps out at like 6 liters a minute, and this we can go up to 20 to 35. So better nasal cannula, non-inferior to our BiPAP or non-invasive ventilation. So this is a great option, and it's a lot more well tolerated than our BiPAP. Some patients find BiPAP to be very uncomfortable. But for these patients, we'll utilize, one or the other, usually BiPAP or high flow. And then let's talk about our treatment. So we are going to break it down into hypertensive heart failure versus normotensive versus hypotensive or cardiogenic shock. So the hypertensive heart failure patients, they usually will have some sort of significant pulmonary edema when they present, and then our treatment is going to be with antihypertensive and nitrites. Nitrates are going to be our big ones that we're going to utilize in these patients. And then if they're dyspneic, which most of them are, we're going to use our BiPAP as well, our high flow. And then we want to diurese some of that fluid off. So after our nitrates, we want to give a diuretic, which is, furosemide is going to be our most commonly utilized one. But here's our algorithm for the hypertensive. So we start with our nitrates. So nitroglycerin is a great option. It's a vasodilator. It's quick acting, rapid onset. And then it'll reduce preload and afterload. So we start with 400 micrograms a minute. And then we continue to monitor until we bring that blood pressure down. But our target's usually around 110 to 120, bring it down to a normal range. And then this will help us kind of prevent that need for intubation if we can control it relatively quickly. Nitroprusside's also another option, but not as commonly used. So we have pulmonary edema and dyspnea, so we want to get that non-invasive BiPAP on them. So we'll usually start with BiPAP if we can, or high flow. Give them the nitrates, thank you. Give them the nitrates, and then we look at diuresing them after our vasodilator therapy. So that's going to be with our furosemide. And we'll talk a little bit about the dosing for furosemide. The next few slides are Lasix. I'm just gonna call it Lasix, it's too hard to say furosemide. But for anybody that's naive, hasn't had Lasix in the past, we'll give 40 milligrams IV to start with, but we'll talk about the dosing here shortly. Next, we have acute heart failure with normal blood pressure. So these patients are normally gonna just be diuresed. So we're not typically gonna have to vasodilate them or do anything else. We're just gonna control the signs of volume overload that we see. So that's what they're gonna get furosemide. We'll look at their IVC on ultrasound to see if they're volume overloaded. But even, you know, if they present with some sort of exacerbation, we're still gonna give them Lasix, whether we see the signs or not. All right, our normal intensive heart failure, diurese first, and then we base all of our other therapy on the response to that diuresis. So are they hypoxic? You know, how is their dyspnea improved? What does their intravascular volume look like? So we can look at that IVC after we diurese them. And then because of the heart failure, they can get that bowel wall edema, it prevents GI absorption, so that's why we want to give it to them IV. A lot of the patients will already have Lasix, and they'll even have instructions for if they're feeling more short of breath, if their dry weight has increased by a certain amount, they'll already have a protocol from their cardiologist on what they should, you know, whether they should take more Lasix that day or increase their dose. And then here's a little bit about the dosing. So it can be a pretty wide range of the dosing. So you'll see people that are a lot more comfortable with, like cardiologists, will give very large doses, like 200 milligrams initially to start with. In the emergency department, most of us are comfortable with giving them whatever their daily dose is, we give it to them IV. So IV is like twice as potent, twice as strong as the oral dose. That's normally what we start with. So if they were taking, you know, 80 milligrams daily at home, that's usually 40 Q12. So we would give them 40 IV in the emergency department. Yeah, we don't typically give morphine for our heart failure patients just because, you know, we've seen poor outcomes or morbidity associated with it. If we have to give some sort of pain control, we will, but usually we avoid morphine. You know, we could use other opiates are appropriate for this, or sometimes we like to use like mild sedation meds can be helpful, especially if they're on BiPAP when we're treating them. In the emergency department, we're not starting them on ACE inhibitors and ARBs. They do show benefit in heart failure, but this is not something we're giving them acutely in the emergency department. This will be managed with their primary care manager. We don't start beta blockers either, even though most of these medications will be given for heart failure and having shown the benefit, but it's not something we're starting in the ED. And then we have our hypotensive heart failures. This is, you know, what we consider cardiogenic shock. So they got systolic less than 90. And these patients, we need to get them on the BiPAP immediately. You know, it may seem counterintuitive. You give fluids to somebody who's volume overloaded, but that fluid may not be reaching the place that they need it to. So we'll still give small fluid boluses, and we start very conservatively, like 250 milliliter boluses to increase blood pressure, or we can use pressors. So in the emergency department, norepi is our go-to for everything, for just about everything. Dobutamine, I usually only do it in consultation with the cardiologist, but it is another option. And that's just because I'm not super comfortable with it. I mean, other ER providers might be. And then we're going to consult cardiology, but like anything that presents with hypotension in the emergency department, we need to resuscitate them. And what are we doing for these patients? Admitting almost all of them. So there are very few of these patients that are going to go home unless they just have very mild symptoms. They ran out of their medication and we're refilling it and they're completely stable, but just about all of them we're going to push for admission in the hospital. And there are, different ways we can risk stratify them, but most of us, they have an exacerbation, something isn't right at home, whether it's compliance or not, they have some sort of issue, like social issue that we couldn't address, so we push for admission in all these. There are different criteria you can look at, but none of them perform better than the clinician's gestalt. And there's the bottom line, admit patients, anybody that's, unstable or they have cardiogenic shock, hypotensive, heart failure, we're gonna send to the ICU. Anybody on BiPAP's gonna go to the ICU, or anybody that we are worried about, we have to, eventually secure their airway. If they're not on BiPAP and they're stable, they can go to like an oxygen unit. But most of them will be admitted. And then here's just, the very few we can discharge home, that was one like, we have a clear cause, usually it's medication non-compliance, they ran out, they couldn't, the pharmacy was closed, or it's a weekend or something like that. Which pharmacies should still be open on the weekends, at least in the civilian world they are. Military, they might not be unless other than the ER pharmacy. So if they, basically if they're asymptomatic, we don't have any hemodynamic compromise, and we can refill their meds, that's gonna be one that may be considered for discharge, but most of them just admit them. All right. Now that was quick. What questions y'all got? You guys look kind of dead inside. Yeah. All right. Well, we have one more lecture. Let's take a 15-minute break and then let's finish it up.
Hey, bike makes sense. Yeah, it's like,
Doesn't have spices, just like,
Are you gonna talk about these fellas once? I'm learning.
Oh, but you guys aren't saying the same thing. It's not. We all know that there's radioactive iodine for the fact that he's talking about pellets. I feel like we've sitting here and learned about this before. Only one way to find out. You got 15 minutes. Each class. Yeah, start a freshman. Why did we not go?
Right over here, just say, yeah.
But I just thought it was funny that they didn't diagnose. You know that meme where it's got like Voldemort?
Use prostadil, prostadil pellets for it. In clinical, you do like see if there's mixed. Same thing, let's start a fire.
But it's in there, then I'm rolling really hard.
Online, just do.
Oh, we got paid.
That's what I'm saying. So we're saying $10.
I'm out. Not taking care of someone. I'm out.
I was in three.
For which one? Top prostate, like the risk factors. So it's
American way in any end.
family history. It was family history, and we just learned about that today. That was for aortic dissection. So let's say what usually like 40 to 45. What about women? Let's say they're how often are you doing it? So they're they turn 50, 51.
They got red light.
It'll be so like the way back, it's about 60 or 35 or that kind of traffic starting the traffic also I think that's what's happening.
All right, you guys ready to keep going? All right, we're gonna move into our final lecture here. It's gonna be DVT and PE, also known as venous thromboembolism. This is a pretty big topic. Can seem complicated. Hopefully I don't complicate it more. We can simplify the approach a little bit, but it is a large topic, and there's a lot of different algorithms we can use. But before we do that, let's do some check on learnings. All right, 68-year-old male with a history of hypertension, medication noncompliance, presents with severe shortness of breath. He is anxious, diaphoretic, speaking in one-word sentences. Vitals are 210/130. Heart rate 125, respiratory 36, SpO2 88% on non-rubber breather. On exam, you hear diffuse swells throughout both lung fields. What are the most appropriate initial interventions for this patient? So what do we think's going on with them? Heart failure? Yeah, so this is going to be C. And this patient's like a, what we call like sympathetic crashing pulmonary edema, acute pulmonary edema escape. But really it's a heart failure patient with volume overload. And they have like a cycle or a sympathetic response that kind of worsens the process. And so these ones we need, high dose IV nitroglycerin and BiPAP does wonders on these patients. All right. We've got a 72-year-old female with a history of heart failure with reduced ejection fraction, presents with progressive shortness of breath, blood pressure 88/60, cool, claim extremities, mental status is declining, focus reveals dilated, poorly contracting left ventricle and a plethoric IVC with minimal respiratory variation. What is the most appropriate next step in management? What do we think? Charlie? Does that sound right? Yeah, so, that patient looks, unstable, they're hypotensive. So we want to give them, some very conservative fluid volume. So we'll start low, and then we'll consider starting a pressor like Norepi is our favorite in the emergency department. Good. All right, you got a 75-year-old female with known history of HFrEF, presents with 3-day history of worsening lower extremity edema, 5-pound weight gain. She is not in acute respiratory distress, vitals are stable, blood pressure 130/80, focus shows a plethoric IVC. What is the most appropriate first-line treatment for this patient? What do we think? Should we give her some morphine? Call it a day? Push some morphine, whatever. Would we say alpha? Yeah. So get her a loop diuretic. So blood pressure's normal. Says it's like a normal intensive. Heart failure. So we want to get some of the, diurese some of that fluid off of her with loop diuretics. All right, 67-year-old male on chronic oral furosemide 40 milligrams daily for heart failure, presents with acute exacerbation. He's normal intensive but has signs of fluid overload. What would be an appropriate initial IV dose? 40 milligrams, everybody agree? Yep, we'll give him his daily dose IV. Good. All right, we got a 22-year-old male brought in by EMS after a syncopal event while running during a PT test. Reports chest pain, dyspnea during running, vital signs are stable as afebrile. And then you hear systolic ejection murmur, chest x-rays normal, EKG is below. What do we see on the EKG? Other than poor image quality. Yeah, we got some, there's some left ventricular hypertrophy on there, some inverted ST segments. Do we see any Q waves on there? Hard to see, but you can prominently see them in V5 and V6. There's like what we call the dagger-like Q waves in there. What do we do for this patient? What do we think it is? Yeah, this one's going to be metoprolol. Really, in the ER, we're admitting this patient, but anybody with HOCM needs to be managed with a beta blocker, but this patient needs to be admitted for an echocardiogram. All right. EMS brings an 82-year-old female with complete sedation and exertion, orthopnea, and pedal edema. Blood pressure is 132/76, heart rate 92, respiratory 22, temp 98.9, SpO2 91%, on 200 nasal cannula. CBC, BNP, and lactate are within normal limits. BNP is 1080, normal is less than 100. During lung auscultation, rolls are heard. You see the bedside ultrasound, the patient's IVC. What is the next best initial treatment for this patient? We agree, loop diuretic. So D, administer furosemide. Normal intensive heart failure. Good. All right, so moving into VTE. So there's our reference. And then we'll talk about epidemiology, pathophys, some risk factors. There's lots of risk factors we're going to cover in this one. What our evaluation is, we'll talk about our algorithms that we can utilize to help us in patients we suspect of venous thromboembolism, and then we'll talk about disposition and treatment. So here's our warm-up case. You got a 49-year-old male, 20-pack year smoking history, hypertension, diabetes, presents to the ED, and you see the picture to the right. He has lower leg pain, swelling, redness. Denies fever, recent travel, chest pain, shortness of breath. Vital signs, blood pressure 162/86, heart rate 94, temp 99.6, respiratory 24, SpO2 98%. So I think we've already harped on the safety net, so everybody, we get, IV, O2 if needed, monitored. What's our differential for this? Yeah, we're talking about VTE, so DVT, but what else?
Cellulitis.
Yeah, cellulitis is a big one, right? So that cellulitis can certainly look identical to a DVT sometimes. Good. What else?
Compartment syndrome.
What syndrome?
Compartment syndrome.
Yeah, compartment syndrome, good. I like it. Perfect. All right, so there's our approach, our ABCs. We'll talk about, the like massive pulmonary embolism are times we're going to have to utilize more emergent treatment in these patients. But we'll cover it as we move through the lecture on what the differences are and when we would use those. So venous thromboembolism, and this is, you know, anybody that has some sort of clot anywhere throughout the body. So most commonly we talk about DVT and PE for these, and that's what we'll discuss today. So, you know, the more common one's going to be, you know, some sort of deep venous thromboembolism, which can be in the legs. We can also see it in other places, like upper extremities, especially if they've had any sort of recent, like, procedures or IVs or PICC lines or anything like that. We can see it in the upper extremities and other areas as well. You can see it in the brain. But the ones we'll discuss today are DVT and PE because they're more common. You know, do you guys remember like Virchow's triad was something we talk about, like the, you know, endothelial damage, stasis, hypercoagulability. There are a lot of different risk factors that are associated with these that we'll discuss. But for PE, we have some sort of clot that gets enlarged in the pulmonary venous circulation and then can cause blockage of those pulmonary arteries and symptoms. So most of them are a process along the same, you know, pathologic framework. So we can see PE with DVT, we can see DVT with PE, and you can see the numbers there. So they're both, you know, pretty relatively associated with each other. And that'll help when we're risk stratifying these patients later on what our treatment is. There will be special populations like pregnancy. We don't want to scan everybody, or we don't want to do a CT scan on everybody. So we'll talk about some algorithms we use for this and what we can do. But, you know, we see this more commonly as patients age. It increases their risk for PE. And then it is the second leading cause of sudden death, unexpected traumatic death. So it is something we encounter frequently in the emergency department. It is something they find, especially on autopsies, reports of patients who just, you know, sudden death. They don't usually make it to the hospital. You know, a small percentage will present with shock or what we call like a massive PE. And it does have a pretty high mortality rate, and we'll talk about what we do for those patients. But the way we like to kind of categorize them for VTE is what do we think the underlying pathophysiology is. So we like to discuss it whether it's provoked versus unprovoked, and that'll it'll make sense with some of the risk factors with this. Do they have malignancy, any recent surgery? Did they have, you know, some sort of immobilization or long flight? That was what we would call provoked. Then we have unprovoked. We don't know what caused it. It's idiopathic, and most of the ones that present to the emergency department are usually unprovoked. And there's, a list of risk factors there. So any one of those provoked. We also want to think about other causes. So estrogen use is a big one that we see a lot. You know, is this caused from a recent infection? Is it just because they're elderly? And this helps later for how long we're going to treat these patients for. So it's unprovoked, usually requires longer treatment if we can't identify what caused this versus we've identified that risk factor cause, and now we can help. We can take care of that and then reduce the amount of anticoagulation they have to be on and how long. But one of the issues we have is the larger the clot, it can, you know, occlude those arteries or the pulmonary system, leading to right vent dilation that can cause myocardial damage. And these are something we see in like the massive pulmonary embolism, so they can lead to, you know, shock and death. But the mechanisms, you got that, you know, acute blockage of the pulmonary artery leads to PEA, asystole, which is no bueno. All right. So, you know, limb immobility is definitely something we want to consider. So these patients can be recent surgeries, especially like hip surgeries are going to run our largest risk for VTE. So we always want to think about this in patients who recently had surgery, they were admitted to the hospital, and we want to look at the time frame from when they were admitted, how long they were non-weight bearing plays a role in this, and then do they have any other risk factors like a recent stroke, so they had a, you know, neurologic deficit, they're not able to utilize an extremity as well as they used to, that can increase their risk as well, and they have a higher probability of getting some sort of venous thromboembolism. When we diagnose, PE or DVT from hospitalization, it typically doesn't happen immediately when they're discharged, so the average time is typically over 10 days later. That's why we have some of the risk factors on here, whether they had the recent surgery on there and how long ago it was, and we'll cover those risk factors. But the larger the surgery, the higher the risk, especially abdominal surgeries. Certain types of cancer, like adenocarcinoma, is a higher risk. Joint replacement, so hip and knee carry a higher risk, hip carrying the highest. And then like any sort of brain or spinal cord, so like neurologic surgeries can also increase their risk or have the highest risk. And then here's some of the cancers. So adenocarcinoma is probably the big one that we see, or the one we probably see more frequently, but also glioblastoma, melanoma, if it's metastatic, lymphomas. So really, anybody with cancer, it kind of increases our suspicion for this. And then, if it's a local procedure, less of a risk. Some still call it surgeries, but usually they're not having to go under sedation for some of these, like a localized breast surgery or biopsy. Family history can increase longitudinal risk, but not really a risk factor that plays a role in here. Gender doesn't really play a role for the first time DVT, but men have more recurrent venous thromboembolisms. Smoking, not by itself, but with other risk factors, acts synergistically and can increase their risk. So if you have a smoker on oral contraceptives, that's something you want to consider. Increase your pre-test probability this might be a venous thromboembolism. Obesity as well. And here's more of our risk factors. So anybody that's 50 and older, they have an increased risk for this. We also will talk about our age-adjusted D-dimer score, because those can be higher as well. We have a significant amount of obesity in our society today, so that also increases their risk, especially if the BMI is over 35. And then pregnancy increases their risk, so we always consider this in a pregnant patient. And then prior history of a VTE is going to increase their risk, so that's something we always want to ask our patients if they had a prior clot in the past. And then our cancers, especially the solid ones. Hematologic disorders like leukemias, myelomas, especially if they've received treatment, they're going to have a higher risk. Anybody with factor V Leiden or thrombophilias are going to be an increased risk, so we want to consider DVT or PE in these patients. Recent surgeries, especially if they had to go under anesthesia or were intubated, it's going to increase it because they're immobilized. Any acute limb immobility, so that's why the hip has the highest risk. You got multiple joints involved. And then anybody that's on bed rest, so hospitalized patients who aren't able to ambulate are going to have a higher risk. Like I said, especially those upper extremity ones, so if they've had any recent indwelling catheters like IVs, PICC lines, that can increase their risk. Long distance travel, that's one we always think about. It's questionable how much of an association there is. I always wondered about it because you sleep every night, right, for hopefully 6 to 8 hours. And you don't get a DVT every night, so it makes me wonder. And I would think you're more mobile in a plane ride than sleeping at night, but that's one we always associate any sort of immobilization, long distance travel. Smoking, not by itself, but that's one we consider, especially with other comorbidities. And then heart failure, so really related to some sort of thrombi or mural thrombi that they can dislodge, and it goes through the circulation. Any strokes are going to increase that risk, especially the first month. Like I said earlier, OCPs, mainly it's estrogen and OCP that we want to consider this with. We also see it with just estrogen after that postmenopausal patient might be on estrogen, so they're gonna have increased risk from age, estrogen, and then if we have other risk factors there, then, you know, it increases our suspicion more. And then there are inflammatory conditions like lupus, it can be associated with IBD. So these are all factors we need to think about when we're evaluating these patients, and these kind of help with our pretest probability of, do I think it's a DVT, what should I do, or VTE at this point. It'll make sense when we go through the algorithms and what we're looking for, or what we're evaluating them for. And then pathophysiology, so you have some sort of ventilation perfusion mismatch. So you have, you know, that occlusion in the artery. They're not, you know, they're able to take a deep breath, but they're not able to oxygenate or move that blood in the area, so it's going to cause that V2 mismatch. And then it can lead to other downstream effects like right heart failure or coronary artery perfusion. So there's kind of like multifactorial what the downstream effects can be from a pulmonary embolism. But here are some of our bigger risk factors. Prior VTE is one we always want to worry about. Recent surgery, did they, you know, have some sort of fracture, like a femur fracture or something, they're immobilized. And then is this a cancer patient? Do they have a history of active malignancy or prior malignancy? And then are they on hormones? Do they have like factor V Leiden? These are all things we want to consider during our history and increase our suspicion for pulmonary embolisms. The symptoms can range basically anything. It's like basically asymptomatic to death. That's kind of a wide range there. Most common thing we're going to see is dyspnea, so some sort of shortness of breath, or what most of these patients complain about. And sometimes it might be a pleuritic chest pain, it might just be a chest pain. But when it says like it's on there undifferentiated, so like we have, these are patients like they're tachypnic, and they have some sort of, you know, dyspnea, and we're listening to their lungs, we don't hear anything in there, there's no clear other finding, like we have a focal finding like a pneumonia. It's somebody we want to consider, could this be a PE? Different studies kind of show whether they have syncope or not. If they have syncope, that usually portends a bad outcome in these patients. It's usually a small percentage, like some of the studies show like 2% with PE will present with syncope. But most of the patients, shortness of breath, some sort of chest pain, whether it's a pleuritic component, which a lot of them will explain, you know, on inspiration, I feel a pain. We always, like, when one of the criteria we look at our scoring systems has hemoptysis, but that's pretty rare. And the most common cause of hemoptysis is just a bronchitis. So, you know, if we have a more likely diagnosis, hopefully we can exclude PE. And then here's some of the abnormal vital signs you see. So they might be hypoxic, tachycardic, tachypnic. The physical exam doesn't predict, or PE doesn't predict any sort of, any alteration of vital signs doesn't really predict how severe that PE is, unless it's a massive PE, and that's going to be the patient, you know, hypotensive and shock, that we're the most concerned about. So clear, like I said, clear lungs. So you're evaluating them. You don't hear any wheezing. You don't hear focal lung sounds. You don't hear ralls in these patients, and you don't have a better explanation. That's kind of how our PE patient presents. You could hear, you know, if they have more significant PE, you might hear that like S3 or one of those loud heart sounds. But typically we don't hear that on these patients. And then how does a DVT present? So normally lower extremity pain. They'll have some sort of swelling, or they may have some sort of swelling in that lower extremity. This, you know, the more reliable signs are like how many centimeters difference is it between the legs. So 2 centimeters below the tibial tubercle kind of increases their likelihood. And that's also on some of our scoring systems. Also, if they had any recent catheters, we want to consider DVT in those patients. So the more proximal the DVT is, the more the worse it can be for those patients. So if it's like if they have an occlusion higher up in the femoral artery, they might present with like that acute limb ischemia or what we have on some pictures here, the phlegmasia, cerulean Dolan's. But we don't have any great physical exam findings. We always learn about home enzyme, but it's not real great for ruling in or out of DVT. So it's something to think about on exam, but not really gonna rule in or rule out the diagnosis of DVT. We do see superficial, like thrombophlebitis, so you can kind of palpate that cord, so it's a little bit more superficial. And it can be associated with DVT, but we don't really consider it DVT. And we treat that a little bit differently, which we'll talk about. And then here's our vascular emergency. So these ones present with that swollen, painful, pale limb. Then we also have our blue limb as well, which is the next one, but this is the phlegmasia albidolens. This is a vascular emergency, so we have an occlusion, they're not able to perfuse that lower extremity, and we want to get them to surgery before they risk limb ischemia or losing that limb. And here's a limb with dusky color, so it's similar to our prior slide. This just has a different color appearance to it. This is a vascular emergency as well, and we want to prevent limb loss, so we're called a vascular surgeon. They can use like catheter-directed thrombolysis or thrombectomy in these patients, but either way, we're calling the surgeon for these, so that we don't want them to lose their limb. But it does have a pretty high amputation rate associated with it if they present with this. And let's move into some of our scoring systems. So did you guys learn the Wells different criteria? It's probably in last semester and some other classes. So we have a couple common scoring systems we use. One of them is going to be our Wells criteria. So we have Wells for DVT and we have Wells for PE. So this one's for DVT, and we score them up on whether we think that, if they're higher risk, moderate, low risk. We also nowadays use mostly whether it's likely versus unlikely versus instead of using like our 3-tiered algorithm, but both of them, both scoring, however you score it, they're still both equally appropriate. So some of the things we want to consider, and we can give them scoring points for it. Do they have any active cancer? So are they getting any treatment right now? Any sort of immobilization, paralysis, paresis gives them a point. Have they been bedridden for over 3 days because of a surgery? Any tenderness along those deep veins on your physical exam? Is the entire leg swollen? So you get points for that. Do we have unilateral swelling? So over 3 centimeters gives them a point. Any unilateral pain edema, and then collateral superficial veins. And then the issue, one of the complaints about the scoring system is there's a subjective portion in it. So do we have a diagnosis that's more likely? So do I think this might be a cellulitis? Do I have signs of a cellulitis? Is the hot, red, warm, tender on that extremity? Do they have a fever with it? So if we have an alternative diagnosis that is more likely in DVT, then that's going to subtract some points. And then that prior history of DVT gives them a point as well, or PE. So that's going to increase their risk. So based on that, we kind of score it. Are they like low risk, so 0 points, versus 1 to 2 is moderate, and then high risk, anything above that. And then we can also use like whether we think it's likely versus unlikely, so that's 0 points versus any points, or over 1 point, then we think it's likely. So there's a lot of different scoring system ways we can do it. Most of it's based on like clinician gestalt and whether we think they have a venous thromboembolism or not. All right. So what do we do for these patients, or what kind of labs and imaging can we use? So our D-dimer is going to be one of our more useful tests that we can rule out a DVT for. It's not one that's great for ruling in a DVT, but it does have a pretty great reliability depending on which patient population we want to utilize this in. So if they're high risk, our D-dimer is not going to be as helpful. We just need to scan those patients. But in our moderate and low risk patients, D-dimer can be extremely helpful to help rule out VTE. And we'll talk about it with our algorithms here shortly. So we want to consider false positives as well, or false negatives in patients. So here are some of the risk factors that can increase a false positive versus a false negative. So the older you get, the higher that D-dimer level is going to be. So we like to use an age-adjusted D-dimer. So it's, if it's a 7-year-old patient, you would just times it by 10, so 700. Normal cutoff's 500 for a D-dimer. Pregnancy can lead to false positive values, so pregnancy will increase your D-dimer level, which is why we use a little bit different criteria for our pregnant patients. So we tend to increase that value to 1,000 in pregnancy, and then you can see it elevated in malignancy, and then really anything that causes immobilization, so recent surgical procedures, you see with RA, a false positive, infections, trauma. So what is our test of choice for DVT? It's going to be our ultrasound. So we get a venous ultrasound. We also call it you might hear it called a Doppler ultrasound because we're looking at flow on there. You might hear it called a compressive ultrasound because we're going to compress that vein on it and see if there's a thrombus in there, and whether we can compress it or not. So you'll see it called a lot of different things, especially when you're ordering this test or on a examination or board question. They might call it DVT ultrasound, they might call it lower extremity venous ultrasound, they might call it compressive ultrasound. There's just something to be aware of. And here's what we're looking for. So on here, and we'll practice these too during our point of care ultrasound blocks. Well, we're looking at the femoral artery and femoral vein. You can see, the labels on there. And then the one on the right, they're compressing it, so you don't see the vein anymore. That's good. That's what we want to see. We want to see a compressible vein so that we can reliably say that, yeah, there's not a clot in there. And then here's what happens when we have a clot. So we're compressing the vein and we don't see any compressibility or collapse. Then we can determine, or we can assume they have a clot in that vein. So sometimes you can kind of see the clot like you can on here. Other times you might not be able to see any sort of hyperechoic changes on there. So it just kind of depends on compressibility. So here's your common femoral artery and vein, and then you have collapse of that vein. That's going to be a normal study. And then here's going to be one with a thrombus. So you have no compression, and then we compress it. We don't see any change in that, and that's going to be indicative of a DVT. What do we see on this one? Play it again. So you can see you have the artery there. You can see the pulsations, and then they're compressing the vein that's right next to it. We don't see any compression, so this would be a positive. All right.
Sir. So you have to do it like right over the top of the
Yes.
occlusion.
Yep. You have to do it over it. And we'll get into what a 3-point DVT ultrasound is during our point of care ultrasound block. So there's 3 areas that we commonly see them in, and it usually covers like 5 to 10 centimeters of that area, and so we can reliably exclude it if we test those 3 different areas, but it'll make sense when we actually do the point of care ultrasounds on each other. So what else, might we see or might be helpful for the diagnosis? EKG is not super helpful. We just have non-specific findings on there. The old adage of like S1, Q3, T3 increases it. You might see it in the PE, but I commonly see S1, Q3, T3, and all kinds of other EKGs, so it's not very reliable. Most common abnormality we see on EKG is going to be like sinus tachycardia. They may have some hypoxia with a PE. Chest X-ray is not super reliable for diagnosis. However, you can have some findings on there that are associated with PE, but there's a very low chance of finding it, so it's not great to rule out PE. And it's coming up on some slides. We have some pictures of like our Westermark and Hampton's home signs. We talked about some of the false positives for the D-dimer, but really any of the risk factors are going to increase that D-dimer. And age as well, so it's something we have to account for with our D-dimer when we're utilizing this test. Other things we want to look for, other causes of chest pain. So, is this some sort of acute coronary syndrome? So we want to get cardiac biomarkers on them. Do we think it's a heart failure? We'll get a BNP. Then we can look at, their CMP and CPC as part of our standard chest pain workup for these patients. But none of them really are going to be a slam dunk for whether this is a VTE or not. And then here's some of our findings on chest x-ray. So you've got Hampton's hump on the left there. So that's like a pulmonary infarction. These are not super common on the chest x-ray. Without the arrows there, would you guys be able to diagnose that like Westermarck sign? I doubt it. I don't think I would. I could probably find the Hampton's hump if it's on there, but like the Westermarck sign could be difficult. And they're in less than 5% of the patients, so it's not something we see a lot. EKG, sinus tach is going to be our most common abnormality. And then they might have non-specific STT wave changes. Now, if they have, a more significant pulmonary embolism, you might see like signs of like right vent strain on there. So that's something to consider when we're evaluating these patients. And then, like I said, that S1Q3, T3, not very common, but it can be associated with it. All right, so there's what the S1Q3, T3 looks like. It's kind of self-explanatory. So you got, the SM1, Q and 3, T and 3, 2 inverted. But we do like to test on these for some reason. All right, what do we see on here? So we see the S1, Q3, T3 on here. I would say we do. What else do we see? Sinus tachycardia, probably going to be what we're going to see most commonly for the abnormality. There's non-specific ST and T wave changes on here, but nothing real specific that says, yep, that's PE or ACS for that matter. All right, so let's get into the more complicated portion of the lecture. This is going to be our risk stratification and how we're utilizing our different scoring systems, our D-dimer testing, and whether we need to scan them or not. And that's the ultimate question, because if you've noticed, the PE symptoms are very non-specific. So a lot of things could be PE. Anybody with chest pain, anybody with shortness of breath, that might be a PE. So let's just scan everybody. And that's usually not the goal. So we utilize these scoring systems for risk stratification. And it can be a little bit complicated at first, but we'll try to walk through this. But the big ones we're going to use are Wells score for DVT-PE, and then our PERC criteria. And then years is a newer one that's out there as well, and it can be helpful, especially in pregnant patients. But what are the goals? So decrease our need for testing, because it can be very nonspecific for PE, so we don't want to scan everybody. These tools can help us decide, do I need to scan them or not? Do I need to do a D-dimer or not? So these are what we utilize these for. And then once again, our clinical gestalt plays a big role in this, which you don't have yet, but you will have it soon. All right. So the first thing we'll talk about is like our PE rule out criteria. So this is a great scoring system or criteria we can utilize in the right patient population. This is one we're only utilizing if we have a low suspicion for PE. So like our initial pretest probability is like less than 15%. I don't think it's a PE, but it could be. Then we can utilize like our PE rule out criteria. So here's our PERC criteria. The first thing is they have to be less than 50. So the patient we would apply this in, they're younger than 50. I don't think it's a PE, but it could be. So then I move into my other scoring criteria. So are they tachycardic? Is their pulse less than 100? Do they have a normal pulse ox? So pulse ox is over 94. There's no hemoptysis. they haven't had a prior VTE, no recent surgeries, they're not taking any estrogen, and then I don't have any signs of DVT like unilateral leg swelling or asymmetric calves. If they meet all of this criteria, and we have that low pretest probability or low suspicion, then we can reliably exclude a pulmonary embolism at this point. Anybody that doesn't meet these criteria, then we have to start working our other algorithms like our Wells score and possibly our D-dimer, depending on the score we're looking for, so, or which one we're using. So with Wells, like I said earlier, they have the low, moderate, high probability. Nowadays, we usually use the like the 2-factor, so is it likely versus unlikely, and then we have the DVT versus PE Wells score. So you guys have MD Calc. Yeah, that's something you guys are going to use a lot in phase 2. So until you memorize it. All right, and once again, the subjective component can play a role in this. So we always want to consider which type of patient we're applying this in, and whether we think there's an alternative diagnosis. Here's our Wells scoring system for PE. So do I think they have a DVT? That gives me 3 points. Do I have a better explanation? If I don't, that gives me 3 points. And then are they tachycardic? Prior VTE always increases your risk. But that gives you 1.5 points. Any surgery or mobilization, active malignancy or hemoptysis, then we're going to get points. So we can utilize these points on whether we think it's low risk, moderate versus high risk. And here's our algorithm. And so this can be kind of complicated, but if we're starting at the top, like, do I have a suspicion that the patient has a PE? So this is when we kind of have to decide whether I think it's low risk, whether I think it's a more moderate risk, and then we kind of risk stratify them into these categories. So if I have a suspicion that it could be, or sign or symptom that it could be a PE, then I want to move into whether I think it's going to be likely versus unlikely. And so the unlikely is going to be, my gestalt, and I think it's less than a 15% chance they have a PE. Then I can move into that algorithm on the left, and I can apply my PERC rule. So if they meet all the PERC criteria, then I can safely exclude a pulmonary embolism and stop testing at that point. Now, if the PERC rule can't be applied or it's positive, then I move into my PE unlikely category, but they have the Wells score. That places them at a more moderate risk, or a more, in the unlikely category, which is normally 4 or less for my Wells score for PE. If we move into that category, then we want to get a D-dimer on those patients. So anybody that has that PE unlikely, Wells, 4 or less score, but I can't PERC them out, then I want to get a D-dimer and base my next testing on the D-dimer. So if it's less than 500 or age-adjusted cutoff, it's less than the score, then we can safely exclude PE. If their D-dimer is elevated, then we have to move into the right side of our algorithm, which is going to be PE's likely. So for this side of the algorithm, we're going to do CT, pulmonary angiogram on these patients, or all these are going to get a CT at this point. So where it gets tricky is whether I initially think putting them into that risk stratification category can help. So D-dimer is only helpful in my lower risk patients. Anybody I suspect that PE in, or I have the likely score, which is over 4, then we're going to move immediately to ordering imaging. So we'll immediately do the CT pulmonary angiogram in these patients. We won't get a D-dimer in them. And then, if we've gotten the D-dimer and they meet it, then they move into the other side of the category for CTPA. Some of the things we have to consider for, CT is what is their kidney function. So we want to factor in their GFR and whether they can actually get a CT scan with contrast, or whether we're going to, further risk hitting their GFR or kidney function. We can also do a VQ scan, not as great. We don't utilize them very often, but it is something that's out there to consider. We'll talk about when we do that. But CTPA is positive, then we diagnose them with PE. CTPA is negative. We can also get lower extremity DVT ultrasounds to evaluate them for DVT, since they can often be seen together. All right. So here's our most common imaging modality. This is going to be our CT pulmonary angiogram or chest CT angiogram with contrast. It can be called a couple different things, but it'll identify a clot. We'll see a filling defect in that vasculature, and it has a pretty decent sensitivity and specificity for diagnosing these. This is going to be our test of choice for all of our PE patients. Yeah, some might develop a contrast nephropathy. I don't know how accurate that really is, and whether contrast nephropathy is a thing. There was just a recent study, I think last month, that talked about contrast nephropathy, and it's not really a thing. But we won't go there. All right, here's what we see on the CT scan, which can be kind of difficult to evaluate these because you run slice by slice kind of going through these arteries, so it can be difficult if you haven't looked at a lot of them. And even if you have, it still can be difficult. But we can see a lung filling defect there. We should see that bright contrast throughout the vasculature, and then with a PE, we have some sort of filling defect in that pulmonary artery. There's a large thrombus. That one's a lot more prominent. You can see where that contrast or that filling defect is, and there is that embolism. And then there's what we call like a saddle embolism, so we got it on both sides. And then there's the VQ scanning. So this just looks for any sort of perfusion defect in ventilation. So these can be difficult to evaluate. Like I don't read these. I don't even know that I've ever ordered one. Actually, most of the time we just get a CT pulmonary angiogram. But it is a test we can consider. Sometimes they talk about it during pregnancy. Nowadays with more advanced CT scanners, we can use lower dose of radiation. So we will still usually scan with a CT pregnant patients, but it'll be up to your local algorithm and shared decision making with the patient. And you can look at what trimester they're in as well and whether there's any risk to that fetus. But I mean, it does have a good sensitivity in excluding PE. And here's what they look like. So I'm assuming the positive arrow sign is some sort of perfusion, ventilation mismatch on there. These ones can be difficult to read. All right. So let's kind of walk through our algorithm again. So do I suspect it's a PE? Do they have a symptom of it? So they might have that chest pain, dyspnea, maybe some sort of hypoxia, tachycardia, tachypnea. And so we have a suspicion for a PE, then we can utilize our algorithm. But we also have to look at whether we think this has, more alternative diagnosis. Like if I hear wheezing or anything, and this is an asthma patient, this may not be somebody that we need to evaluate for PE. Next, we need to look at, do they have any risk factors for a PE, so we can use our different criteria. So if I have a sign or symptom, I can apply and I have a low pretest probability or low, my Gestalt says probably not a PE, I can use my PERC rule, or I can use my Wells criteria to help rule that out. Now, if I have more than a low suspicion, these are patients where we apply some of these algorithms. So I can't use my PERC criteria. Then I need to look at whether I need to order that D-dimer test in these patients. So low initial suspicion, can't PERC, gonna get a D-dimer. And then usually we start with that D-dimer. If it's positive, then we decide whether we're treating it, whether we suspect DVT versus PE. And we'll order our testing from there, whether it's an ultrasound with a positive D-dimer versus whether it's going to be that CT pulmonary angiogram. And so that's kind of what I just said. Anybody that has that positive D-dimer, we're then going to scan them looking for any sort of PE. We can do the lower extremity ultrasound if you suspect a DVT, but we want to make sure we apply all of our scoring rules into the right patient. So there are some tricky categories on here. So let's say you had a patient, you had, their well score, put them into the D-dimer category. Our D-dimer is positive. Then we do an ultrasound and we don't find a DVT. So the question is, what do we do with that? A positive D-dimer, negative ultrasound, and this happens a lot. So these patients, we can't say they don't have a DVT, but less of a risk DVT. But in order to rule it out, we have to have them follow up in usually the next 2 to 7 days. Usually we say 5 to 7 days. They need to come back, get a repeat ultrasound. If that's negative, then we can say they don't have a DVT. All right. And then for treatment, we'll get into it here in a sec, but DOACs are going to be our most common treatment that we're utilizing nowadays, especially in the outpatient setting. And then here's what I was just talking about. So we get our pretest probability using our Wells criteria, low probability. We get D-dimer negative ruled out, D-dimer positive. Then we get the ultrasound. And if they have a DVT, we treat it. If they don't, then we can rule it out. If it's D-dimer positive, ultrasound negative, repeat in 5 to 7 days. All right. So stable patients with the venous thromboembolism. So this goes for DVT and PE. And we like to use DOACs are going to be our common first line treatment now. There are some, we do have to consider kidney function in these patients, so that can be affected and that can change our dose. But these are going to be the most effective now, but they're also usually the cheapest, most well tolerated. We can send them home. Things like I said, consider any dialysis patient or anybody with decreased kidney function, which we can adjust the dosage on the apixaban for that. But pregnant patients are another one. We don't give DOACs in; they're contraindicated. So if you have a pregnant patient with DVT, we want to give them the low molecular weight heparin or Lovenox is what the preferred treatment is going to be for those patients. All right, so when I discussed at the beginning for provoked versus unprovoked, that kind of determines how long a treatment they need. So if we have a provoked venous thromboembolism, then we can do 3 months of treatment. And that's normally done by their primary care manager. And then anything that's unprovoked, it might require longer treatment, like 6 months to 12 months, if we can't decrease any of those risk factors that they have. And then some people will be on anticoagulation for the rest of their lives. So that's very common. You'll see that in a lot of patients, especially if they have risk factors that we can't modify. But any patient that's well appearing, they can have good follow-up, they're stable, then we can treat them outpatient with one of the DOACs. Upper extremity DVT, treat the same way, except we want to make sure we remove whatever caused that clot, because normally it's associated with some sort of indwelling catheter, so we want to take that out. And then start them on a DOAC. We utilize the same treatment for them. Like I said earlier, any of the phlegmatia or anything that has or risk for complete occlusion or limb ischemia, then we want to call the vascular surgeon immediately. So we start anticoagulation, we call the surgeon, and we go and we admit them or they take them immediately to surgery to prevent that limb ischemia. What do we do for superficial thrombophlebitis? Really nothing. We give them anti-inflammatories, maybe some anti-inflammatory gel, and then we send them home, follow up with their primary care manager. We don't have to systemically anticoagulate them with a DOAC or anything like that. And then, compression stockings don't do anything, but we still tell the patients to wear compression stockings. It's kind of like, when they have a cold, the meds work, but we still tell them to take them. Because we don't want to look like we're doing nothing for people. All right, so once again, stable patient, they don't have any significant comorbidities or any indication for admission, we can treat them as outpatient with a PE. Yeah, we don't really keep in the ED for 23 hours, but they can have a short-term hospitalization if we have any high-risk features like other findings, elevated trope, BMP. If we suspect like any pulmonary hypertension or find any abnormal EKG, we may want to consider admitting them versus discharging them home. And then one of the other issues is do they have good access to medication and follow-up? So if we can get them a prescription and they can follow up with their doc, then they can go home and be treated as outpatient. And here's our different medications that we can use. Unfractionated heparin, that's going to be more on the inpatient side. It requires an IV, so that is going to be a patient that either we can't send home, has renal failure, or they need admission to the hospital. Lovenox is also a great option. That's sub-Q. The other ones on here we don't use as often, just because some of them require a bridge or it can be affected with renal failure. And then our two most common are going to be like our rivaroxaban and apixaban are going to be like our two go-to medications. The studies show Eliquis is probably a little bit better, but it's not like definitive. Rivaroxaban's cheaper, so you'll see that used more in the civilian world. We like to use the apixaban or Eliquis in the military because we use monopoly money and it works better. The other ones on here, we have to have like bridge to therapy, like dabigatran, so we don't use that often. They'll have to be inpatient for that, so it's not a great one for outpatient management. And then we got our fibrinolytics on there, our TPA, and that's for our massive PE. So here's how we categorize it: PE, massive, submassive, or like less severe PE. So massive is anybody that's unstable. So they present with shock, they've got hypotension. You can find it on like if you have ultrasound findings as well of like the right heart strain. But really this one is more of a clinical diagnosis of what their vital signs are. So at that point we call it massive PE. Submassive is they're really, relatively normal blood pressure. They're not hypotensive, but they can present with other signs like they're tachycardic, tachyp, and that would be like a submassive PE. But the patients that have a massive PE, those are ones we consider TPA or fibrinolysis in. So it has shown there is a benefit giving them fibrinolysis with these patients. It does improve mortality. And we have to consider those kind of same criteria for fibrinolysis contraindications as well. Patients we also use fibrinolysis in are like our cardiac arrest patients. So if we remember our H's and T's and all that, that's something we consider. And if we suspect that this is like a massive PE causing a cardiac arrest, we'll give fibrinolysis during that code. And here's some of the major contraindications. There's an entire checklist, so I won't get into all of them. But big ones like intracranial disease or recent intracranial surgeries. We need that uncontrolled hypertension, so we like to have their blood pressure, the systolic under 180 prior to giving this. Any recent major surgeries and cancer. Other treatment options, you can do catheter-directed thrombolysis. So this is just a lower dose of that TPA provided to the patients through a catheter where that clot is. And that's something we'll have to get, usually done with interventional radiology, not done in the emergency department. So these are what the more definitive treatments, like we're calling our specialists to come in and take care of this. We can also do surgical embolectomy. And still pretty high mortality with it, but it's better in a younger patient if they get that surgical embolectomy. That's going to be up to that's going to be up to the vascular surgeons what they're going to use for this. So anybody with severe PE, like that massive, or anybody with like submassive and kind of questionable vital signs, those patients are all getting admitted to the hospital. The massive are going to go to the ICU. most patients, we can treat this outpatient with anticoagulation. So they got normal vital signs, they have good follow-up with their doctor, they can fill the prescription. Then we'll treat them outpatient. Pregnancy is a special population. So, you know, there's, the historic teaching was we don't want to scan any of these patients. Nowadays, we use more shared decision making with the patient, explain the, you know, the radiation effects that CT can have on the fetus, and it's very low risk nowadays, especially with the newer scanners out there. So we just want to, you know, share that with the patient and decide whether they're okay with getting a CT scan, which is usually the preferred option. But something we need to think about with these, or the other algorithm we can use on here, if they don't have, if they don't want to get a CT or they're not a good candidate for it. A lot of places aren't doing VQ scans, so that's why we have to utilize the other algorithm. So what we do in real life is patient comes in, we can use our D-dimer in these patients. We have a year's algorithm, which is newer, and we're not testing on it. But so D-dimer's over 1,000 in these patients, and we don't want to scan them. We'll get bilateral DVT ultrasounds in these patients. So if we've, you know, if we have a positive ultrasound, then we'll treat them with Lovenox. If we have the negative bilateral DVT ultrasounds, then we can, and we still have a high suspicion for PE, then that's when we'll consider doing a CT scan in these patients, the CTPA, and have the discussion with the patient. Other options, if we still have a high suspicion, you know, we can discuss it with the patient, possibly anticoagulating them as well. And those would be patients with like prior DVTs or other risk factors that we're just going to treat them versus scanning them. But it's something to think about. All right, I know it was a lot. What questions do you guys have?